Everyone, thanks for having me. My name is Samuel Washington. I'm a urologic oncologist here at the Department of Urology at UCSF and a former CADC scholar for the 2018-2019. Thank you for allowing me to present my work, which looked at how race modifies survival benefit for guidelines-based treatment and the implications for reducing disparities in muscle-invasive bladder cancer. I have no disclosures for this presentation. Briefly, I'm just going to go over background for bladder cancer. Urology being what it is, people know that we exist, but have no idea what we do, particularly for bladder cancer, which is such a specific subset within urology. Then I'll review the aims from each portion of my proposal, as well as future directions and next steps. So within GU cancers, bladder cancer is a major contributor of morbidity and mortality. It remains a disease of largely older individuals, those over the age of 50. In 2021 alone, there will be an estimated 83,000 new cases diagnosed and over 17,000 cancer-specific deaths due to bladder cancer alone. Despite this this overall higher risk of mortality relative to other GU cancers like prostate, our knowledge about the impact of disparities and the timing of diagnosis and clinical outcomes remains largely limited. Now, taking a step back, how do we treat advanced bladder cancer? There's really two main options that have been consistent for the last 20 or 30 years, which is cystectomy, removing the bladder, plus or minus chemotherapy before or after surgery, or a combination of removing as much cancer as we can, leaving the bladder in place, and then treating with chemoradiation. Now, we know that overall, we've continued to see Black patients present with worse stage disease and worse survival at 5 years. But the current state of disparities, at least within my own field, is a lot of this is attributed to access and care. And these are largely, again, studies focusing on differences between Black and white patients. But how do I use that to inform interventions? I'm not really providing anything, just broad categories. And at the end of the day, all of these data sets being used are people who have access to care. They were diagnosed in some sense. So there's a disconnect between access and what happens afterwards, leading to survival or worse survival outcomes. Now, explaining these disparities, we always seem to stop, at least within my field, within access to care. But we know that the type of treatment, when you get it, when you receive it, are all things that impact survival. So is the effect in disparities in receipt of guidelines-based care impacting outcomes within groups? So some Black patients with muscle-invasive bladder cancer are going to get guidelines-based treatment, others will not. Now, that disparity within the group, how is that contributing to the disparities we're seeing across groups? And that's really what we tried to look at with this study, was to look overall at how disparities in guidelines-based treatment impact survival outcomes across racial and ethnic groups. So aim one was really to look at how race influenced receipt of guidelines-based treatment. And then aim two was to look at how disparities in receipt of guidelines-based treatment influence survival. So for aim one, we used National Cancer Database and identified over 51,000 individuals with locally advanced non-metastatic bladder cancer. So advanced cancer within the bladder, but had not gone to other parts of the body. And then we clustered to look at within a facility, are there differences by race, ethnicity after adjusting for clinical, demographic, and then local variations in economic factors. We saw, broadly speaking, it was kind of shocking that less than half of patients received guidelines-based treatment. We look specifically at Black patients, we see roughly a third of those received treatments dictated by our guidelines. Now, if we looked within the same institution, we saw Black patients were 21% lower odds of receiving guidelines-based treatment compared to white counterparts, adjusting for all the factors we discussed beforehand. We actually saw that odds became even worse when we restricted to higher volume institutions. And we see that again, that disparity increased. So now Black patients were at 32% lower odds of receiving guidelines-based treatment if we restricted to government-funded insurance like Medicaid or Medicare. For the next part of our study, we looked at, again, how that disparity in receipt of guidelines-based treatment by race is impacting survival differences we're seeing across groups. So again, we clustered to look at how facilities are associated with differences, adjusting for race, age, gender, tumor characteristics, clinical staging data. But then we also looked at how the receipt of guidelines-based treatment, yes, no, interacted with race to contribute to the survival differences observed. In this one, we used a slightly more relaxed definition, looking at more advanced cancer. And in this subset, we, again, using National Cancer Database, we saw almost 55,000 patients with locally advanced muscle-invasive bladder cancer. So in this group, people with advanced disease in the pelvis, but had not extended outside. Still guidelines-based treatment or guidelines-based dictations for what should be done remain the same. We saw in this cohort, 90% of patients were white, 7% Black, 3% Latino or Hispanic. The majority of those had T2 disease, meaning that it was confined within the bladder without evidence of lymph nodes outside of the bladder being positive, and had the most common type of pathology that we see within urology. Now, the little over a third were treated at an academic center, and nearly half were treated at a comprehensive cancer center of some kind within this data set. Even here, we saw only half of patients received guidelines-based treatment overall. Now, we saw when we looked at those who received guidelines-based treatment compared to those that did not, interestingly enough, we saw that those that were younger, those that were white, those diagnosed with urothelial carcinoma, those who were privately insured, and those treated at academic facilities all had a higher, were more commonly treated with guidelines-based treatment. But when we looked at race, ethnicity, and the guidelines-based treatment status, we see that the benefit is not the same for everyone. So not only are we seeing, as expected, those who receive guidelines-based treatment doing better, but we also see within groups differences based on GBT status, and then also GBT status and race, seeing differences across these groups here. Now we know that looking at this further in terms of mortality hazard or the risk of dying, Black patients continue to have a higher mortality hazard or mortality risk compared to white and Latino individuals, even after adjusting for all these factors. Now, the relative hazard when we looked at white and Latino individuals was near equivalent for reasons we couldn't explain based on the variables we have in this data set. Now, we know that Black individuals with guidelines-based treatment had nearly equivalent hazards as Latino counterparts without guidelines-based treatment, which was interesting and surprising. Now, this observation has been seen in other data sets and other disease processes, but it was interesting to find this in bladder cancer, which is quite aggressive on the scale of GU cancers. Now, overall, we had to take a step back and see that globally, guidelines-based treatment is underutilized in all groups, but this doesn't explain all the disparities. We're still seeing the impact of a lot of different factors, only some of those being measured in this analysis in terms of economics, food, education, healthcare access, and implementation, and then social and environmental factors. So again, deeper work needs to be done into the systemic and institutional barriers to guidelines-based treatment, qualitative studies to better understand interactions, concerns, and experiences of patients. All of these are factors that are not commonly collected in national cancer registries, but are factors that can contribute to the differences that we're seeing. And then also for such aggressive cancer, understanding a potential benefit of patient navigation or some way to facilitate passage through this medical evaluation and treatment pipeline to reduce disparities. And lastly, financial burdens and barriers to care is again being another source of disparities that are not clearly defined within bladder cancer. Thank you for the opportunity to present. Have a great day.